The next session is going to be the debate for our postgraduate students. May I invite Dr. Nilanjan Mitra and Dr. Bodul Shah to take this session forward, please.
Welcome all. We are starting our academic program right now for the PGTs. The debate is going to start. May I call upon the stage Dr. Ankit Sandhu and Dr. Vijay Ola to sit nearby. The first topic of the debate will be thulium fiber laser versus holmium 30-watt laser. Which one to buy? Can you show the presentation?
Before proceeding to our debate session, I will like to give a message to all the debaters that you should strictly follow the timetable, as there is also marking on the time. So everybody should follow the time guideline, which you have already been informed.
Time is 6 minutes and each one will be given 2 minutes for rebuttal. We are having some technical problems for starting the presentation. This is a competitive session and there are monetary prizes for this also, for winning the debate. Okay, let us start the debate. I think all are third year who are going to join this debate. So you will be passing next year and will be going through private practice. So if you need a laser to do your stone surgeries, so which one will you like to buy? A thulium fiber laser or a holmium 30-watt laser? Which one will be affordable for you and will help you in doing all the surgeries? So please, Dr. Ankit Sandhu, come up to the stage and start your presentation.
Good afternoon, everyone. Thank you, Buscon family, for providing such a beautiful opportunity to present debate. And special thanks to our guest of honor, Dr. Pal sir, for providing the opportunity. My topic is thulium versus holmium laser. And the scenario given is a young radiologist wants to buy a laser machine for stone measurement. Which one he should buy, a thulium fiber or a low power holmium laser 30? Then, with the recent FDA approval in 2019 and the European CE mark approval in 2020, thulium fiber laser technology has become more widely available. TFL has become one of the most awaited innovations in endourology. The TFL is called a fiber laser because the laser beam is generated inside a very small core laser fiber, the game medium, with a laser generator. As is evident from the picture itself, thulium fiber laser is a compact, portable, easy to manage device, whereas holmium laser is a very complex, heavy, and not able to not portable device. Now, this one is a landmark systematic review which compared the holmium and the thulium and set the milestone for the new innovative technology. Now, thulium fiber laser is basically a diode laser where thulium doped chemical is produced in 20 to 20 microcore diameter. It is pumped by diode laser, but electronically modified to alter the temporal beam profile. Whereas in holmium, it is a complex procedure where it requires wide xenon light and crystal. Now, TFL property absorption in water is 4.5 times of Hoyag and emits a wavelength of 1940, thus closely matching the near infrared absorption peak of liquid water at 22 degrees centigrade. There is a formation of bubble stream with multiple bubble expansion which collapses. This phenomenon is reminiscent of Moses effect, a vapor channel resulting from water irradiation by laser and which leaves an open path with low absorption coefficient between fiber tip and stone surface, which is very well explained in the next video. Please play the video. Kindly play. Yeah, the lower one is the Thorium fiber technology and the above is the HOYAG. We can see a very, a kind of continuous and a powerful laser bubble being formed in the Thorium. In an article by Oliver Traxler, the famous urologist, the Thorium fiber laser, the new player of the kidney stone treatment, the comparison of HOYAG and Thorium was done, and which shows that Thorium reduced wavelength 1940, pulse energy as low as 0.025, pulse duration as maximum as 12 milliseconds, pulse shape is electronically modulated, maximum pulse frequency we can achieve 2000, which gives us a variability, and maximum average power of 60 watt. And diameter can be as low as 50 micron, and cooling system only fan is required in compared to Hollap, which is a complex which requires a water cooling mechanism, and resistance to external shocks is high. TFL is a promising, in an article by Hardy et al., TFL high power holmium YAG versus Thorium fiber laser. TFL is a promising alternative laser for lithotripsy. When operated in dusting mode, produces higher stone ablation rates and smaller stone fragments than the holmium laser. And the laser of the future in the technology, where now in this we can, in the article it has been explained about the speed, where TFL has up to 4 times more the ablation than TFL, dust size is more, and higher dust quality and better dust quality in TFL, significant absent retropulsion in the TFL, and as low as 50 micrometer diameter. Then laser setting, it provides a comprehensive set of laser setting which can modulate from 0.2 joules to 2 joules and frequency up to 2000 hertz. In a paper by Vincent D. Koenig, dusting efficiency, it was twice as much more than HOYAG. And same preclinical study by Andrevia shows reduced retropulsion, even absent, and visibility was almost 95% cases was fine. Then safety, which is a concern, temperature rising with the TFL fiber, it has been shown it's as good as HOYAG, and moreover with the intermittent activation and high irrigation flow will rise to no lead of temperature. Thorium fibers, next study by Encreeve, Thorium fiber laser for lithotripsy. It shows they had a study where mean stone size was 12.5 and density of 119, and operating time was reduced to 23 minutes. And a study by Dimitri and Kev showed their first clinical experience, the high laser power, 25 to 40 watt up to Thorium, had even no effect on urinary tissue, and TLF was safe, no case of stricture was noted at 3 months. And now to fire burn back with TFL is as low as 0.2 millimeter as compared to Hollap, which is about 3 millimeter, which is for our daily use, where if fiber is burned, then we have to buy another again and again. And now especially in case of inferior lower calyxal stone, where we have to bend the fiber a lot, then during the activation in the fiber itself, the breakage of fiber fracture curve was almost nil for TFL, but it was a significant risk for Hollap. So it has an advantage over Thorium. So next generation laser lithotripsy, what do we need? We need small fibers, with a better irrigation flow, better instrument, and fiber as small as possible. So in nutshell, these are the studies which support Thorium, and in nutshell we can say it's like we want to buy a Tesla car or a Honda car. Tesla is like a Thorium, and which is innovative technology yet to be awaited in India. In some cases it has been there, whereas Honda is a petroleum based, where we can have a tested old girl standard. So take home message that integration of small fibers with a core diameter as 50 micrometer, pulse energy as low as 0.025, and super high pulse repetition range up to 2000. So thank you.
Thanks, Ankit, for your wonderful presentation for why to buy a Thorium fiber laser. Next, the turn comes for Dr. Vijay Ola to go for the holmium low watt holmium laser.
Ankit, you take a seat. You will be Ankit, you take a seat in the front row. You take a seat in the front row.
Good morning, everyone. I am Dr. Vijay from R.N. Tagore Hospital, and I will be talking in favor of low power holmium laser. Thorium fiber laser or holmium laser? This question has been asked multiple times in recent years, and even Oliver Traxler says that there is no clear answer to this question as of now. Papers have been there for more than a decade, and this paper was published in 2011, which says that both lasers produce comparable ablation rates. This is a recent article published in BJUI in 2021, which also say that further randomized trials are warranted to delineate thulium fiber lasers' formal position as well as determine the optimal settings for use in clinical practice. These are various articles in various journals published in recent years, but the conclusion of all these articles is same. And the conclusion is that large multicentric prospective clinical studies with long-term follow-up are needed to establish the safety and efficacy of thulium fiber laser in endourology. So thulium fiber laser has a long way to go. In contrast, holmium laser is a gold standard in lithotripsy. It is suitable for fragmentation and dusting all stone types. It can be operated with thin and flexible fibers. It has a favorable safety profile, and it can be used for soft tissue applications also. In contrast, thulium fiber is a dusting laser. It is not clear that it is superior to holmium YAG laser for fragmentation or not. Peak power generated by thulium fiber laser is also very low. Fragmentation of impacted ureteral stone is very difficult with TFL, and level 1 data comparing holmium YAG and thulium laser is urgently required. It is said that it has been 4 times more effective, but really is this so? What does the bench study say? They say that at max it is 1.5 times more faster than holmium laser. But here we are dealing with larger stones. Things for biological stones may be completely different. This study was published by Nadyar group, where they compared thulium fiber laser with holmium laser, and what they found? They found that total laser time, operative time, and stone fragmentation rate all favors holmium laser. And when they split this data into soft and hard stone, soft stone may be slightly fragment faster with thulium fiber laser. But for hard stone, total laser time was almost half for holmium laser in comparison with thulium fiber laser. This study was done by Oxford and published in AUA 2021, where they compared 35 to 45 watt lasers versus working distance from stone. And here we can see that holmium laser has score over thulium fiber laser at all stone distances. There has been no safety concern regarding holmium laser, but there has been a huge safety concern regarding thulium fiber laser. This first article was published in Endourology Journal 2021, where they say that high-power thulium fiber laser setting may create temperature within the collecting system that could result in urothelial tissue injury. This was another article published in AUA 2021, where they say that thulium fiber laser generated 11% higher T average and 48% higher T maximum compared to holmium at 30 watt settings. This AUA article also says that thermal injury to human tissue can occur after 20 minutes of exposure to 43 degrees Celsius. And when we increase the speed of irrigation to mitigate this heat, it comes with potential drawbacks of sepsis and hemorrhage. And here are the results of temperature profiles for various lasers. Here we can see that thulium fiber laser, which is represented by blue line, has generated more temperature at any peak power than holmium laser, and at 30 watt, it is near the dangerous levels. Most of the stones we see in our clinical practice are upper ureteric stone, and most of them are impacted. So be careful while treating these stones. Always use holmium laser and never use thulium fiber laser. This was also discussed in AUA 2021, where Oliver Trexler himself said that the problem with high frequency in a limited space is that it is very difficult to control all pulses, and there is a big risk of mucosal damage. What does thulium fiber laser promises? It promises that it is quite stable, compact, maneuverable, and easy use interface. But I am not looking for these non-clinical functionalities. I am looking for clinical versatility. I am looking for optimal settings, no heat generation, no bubbles, no churning, and no flashing. Peak power generated by thulium fiber laser is low in comparison with holmium YAG laser. So the effective fragmentation is also low in comparison with holmium YAG laser. And there are concerns regarding carbonization, flashes, spark, and smoke with thulium fiber laser. This was also discussed in EAU 2021, where they said that the technique cannot be called really no touch, as we do for holmium laser, because the peak power is very different. Therefore, we have to be very near to the target. Even Oliver Trexler also says that yes, there is a strange carbonization effect with thulium fiber laser, and there is no such effect with holmium laser. Oliver Trexler has also intermittently said that low power holmium laser is enough to perform RIRS safely as well as perfectly. And this was a tweet done by Oliver Trexler, where he said that thulium fiber laser is fast, but at the end of the procedure, there is plenty of dust and microfragment with high risk of stain stars and DJ blockage. So don't be too optimistic with thulium fiber laser. And this was a systemic review article which assessed 375 manuscripts, and what they say that thulium fiber laser lithotripsy shows promising results, but further prospective randomized trials are required to properly assess its usability, clinical effectiveness, and standardization of the setting for successful adoption of the technology. In conclusion, I have to say that holmium is an effective and safe technology for treatment of urinary stones in almost any patient group, ranging from young children to adults and older patients. pregnant women to spinal cord injury patients, from solitary to allograft kidneys, or patients on certain medications and anticoagulants. Its safety profile has been largely demonstrated in countless and recent safety-oriented studies. Thank you.
Thanks, Dr. Vijay Ola. Please, Dr. Ankit Shadhu, please come up the stage for rebuttal. As Dr. Vijay Ola has told that there are some disadvantages of using thulium fiber laser for the young urologists, especially in the upper aortic stones. And also you have to keep in mind the price thing, because you are a young urologist and you are having not much of money. So which one to buy for yourself? Please give stress on that.
Thank you, sir. My colleague has wonderfully explained the side effects of thulium fiber laser, but I would like to point out that a tweet is not regarded as the original article or a valid rebuttal point. And regarding what you said about first the safety of about temperature, it has been already mentioned that though yes, TFL reaches the high temperature, but intermittent activation and high irrigation flow is required. Second, miniaturization of the concept of miniaturization, which is being prolonged, which is the next coming technology in future. So we have to be ready for future rather than dwelling in the past. So we thorium fiber laser with its core diameter as low as 50 micrometer provides that thing. When we will have a RAS scope of 7 French or 6 French, then holmium 200 microfiber will be out of date. That will be of no use to us. But rather, when we adapt ourselves to the handling of the miniature fibers like 50 micro core diameter of TFL, then we are also investing in the future. Yeah, cost is at present is a limiting factor for TFL because it's a, no doubt, it's a newer technology. Even before laser, there was pneumatic. Holmium was also a new technology once upon a time, and further studies proved it to be now a gold standard. So thorium has in its initial stages, and clinical studies being performed, preclinical have provided the data that it is a better and a safe and efficacious laser than holmium. And further studies in coming era, because studies have started only from 2019 and 20, we don't even have a kind of long-term, more than 1 year study, only 3 months data we have available. But as the time passes, it will definitely will provide the results which we are looking for and will give the benefit of investing now. In the cost, it said at present, it is cost is around 60 to 70 lakhs for a 60 watt. Holmium we can get in a better way, but looking for the future and our investment, I can say we can safely invest in TFL. Thank you.
Dr. Vijay, it's your turn for rebuttal. Please come up to the stage.
Thulium fiber laser may be a laser for future generation, but as of now, it has a long way to go. And there are more level 1 evidences required to prove its superiority over the holmium laser. In contrast, holmium laser is an old war horse. It is time tested, it is versatile, and it is still the established gold standard. Why a young urologist would spend his money on a laser machine where he doesn't know about the temperature, the vibration effects, and the backburn effects? So in my opinion, the young urologist should go with low power holmium laser, which is readily available, and the most important thing, which is cost effective in comparison with thulium fiber laser. Buying a thulium fiber laser at present is just like mutual funds subject to market risk. So play safe, don't be fooled by what is popularized and advertised, and a young urologist should go with low power holmium laser, as you can easily accept it in your clinical practice. Thank you.
Dr. Vijay, please stay on the stage. And Dr. Ankit, please come up to the stage. Any questions from the audience, sir? Or we shall move to the next debate.
No, both have presented quite well, and they have highlighted what are the pros and cons of each. But if you see from the realistic point of view, and as he pointed that from the young urologist point of view is actually going to start the practice From that point of view, what you need to see is that what is the maintenance? Because if you see the holmium laser, what are the disadvantages of holmium? Is that the maintenance cost is very high. You need a lot of modification in the electricity generator and the power. Then the other disadvantage of holmium is that it is stationary. It is not a portable machine like a thulium. They provide a bag on which you can carry out. Many of the young urologists who start practice, they practice roaming practice in the beginning, and they go at different places to do the cases. The thulium they can certainly go and do at different places. They can carry it over. Third thing, what a young urologist has to see is that what is the purpose of his taking that particular laser machine, whether it is holmium or thulium. Most of the people, they will use it for the stone purpose. Now, for stone purpose, you don't need high power energy either from the holmium or from the thulium. So low watt energy, the machine for the holmium laser and the thulium, the cost is almost the same. The other advantage of thulium fiber laser is that thulium fiber, when you are restricting to stone disease, is that the fibers are becoming smaller and smaller. The limit of holmium fiber laser is 240 or 200 at the most micron, whereas now the thulium fiber is coming with the 150 micron and they are coming with the 100 micron, which is there, which is going to come in a short time. Advantage of the smaller laser fiber is that when you are doing RIRS, when you want to go in a different chalasis, especially in the lower chalasis, if the fiber is bigger, then the bending of the scope is restricted. Whereas with 100 and 150 micron fibers, the restriction is not there. So there are many advantages of TFL, but as he rightly pointed out, that the ureteric stone, when you are treating, the temperature is not yet studied, and there are concerns which are definitely raised that the long-term follow-up and the stricture rate with the thulium, especially in the ureter, where there is a small area and the heat is generally going to affect the mucosa and will result into the stricture formation, is a great concern. And so as of today, this is a situation. Thank you.
Thanks to Sabnis sir for the wonderful summarization of the whole of the laser thing. Any other questions? So you please leave. The next set we are going to start. We are going to call upon stage Dr. Vishal Kashyap from NRS Medical College. The topic is left renal pelvic stone, whether to go for a PCNL or a lap pyelolithotomy. He's a 65 years old male who complains of a left flank pain on and off since last 5 years and increased since last 2 months. There are no complaints of fever, nausea or vomiting. This is the size of the stone as shown by a straight X-ray. And this is a size of about 3 centimeter in CT scan in the pelvis. So your turn for PCNL, Dr. Vishal Kashyap.
विशाल पिसिंग ये नीचे स्लाइड कैसे करेंगे नीचे okay thank you good afternoon my respected teachers my seniors and my colleagues and my dear junior today my topic of debate is the left renal pelvic calculus size approx 3 centimeter firstly I am just discuss about the patient details. My patient is the 65-year male, complaint of the left flank pain on and off since last 5 years, increased since 2 months, no complaint of fever, nausea or vomiting. It is the X-ray KUV plate showing the radiopaque shadow in the left renal area. Most probably this is the renal stone. It is the CT scan plate, axial view showing the exact size of the stone, which is the transverse diameter is the 29.4 mm and the vertical diameter is the 29.6 mm. It is located in the pelvis. It is the radiography plate. It is the coronal view of the CT scan. I think all are sitting here, the urologist, and no any urologist is thinking about this management of this case. I think PCNL is the best for this case. Why? There is some point of the contention. PCNL is the single incision surgery. Just half-inch surgery is enough for the huge stone. But in the laparoscopic, you must at least 3 port, 1 10 mm port, 2 5 mm port. But there is the big challenge for the laparoscopic surgery. Big challenge is the stone size is the 3 centimeter. You can't remove the in toto stone by the 10 mm port. So you must enlarge your incision up to the 3 centimeter for the benign condition. And I think no one urologist want to enlarge the incision for the benign condition, and no one patient is wishing for the post-op large scar. So there is the very good, efficient, and the best management for this large stone is the PCNL. PCNL can be done in the spinal anesthesia, regional anesthesia, and the GAs also. PCNL needs very few assistants. PCNL, you can do the PCNL with 1 assistant, but in the laparoscopic, you must need the 2 assistants. In PCNL, in every urology OT, C-arm and pneumatic lithotripter is the basic infrastructure. There is no any extra needed. But for the laparoscopic surgery, you must need the CO2 insufflator machine and the other things. So it is the cheapest in also. All urologists are the specialists in the endourologist. So it is a learning curve is the very less than the laparoscopic surgery. For the lap pyelonephrotomy, you must be skilled in the suturing technique. It is not a normal laparoscopic skill. You must be extra skilled for this case. Actually, my patient is the 60-year male. According to the American Society of Anesthesiology, it is the high-risk case. My patient might be the ischemic cardiac diseases, respiratory problem, and why my patient is facing such a problem due to insufflation. And during the insufflation, there is the chances of the neoperitoneum complications, such as the bowel insufflation, gas embolism, barotrauma, subcutaneous emphysema, pneumomediastinum, pneumothorax, and the pneumopericardium. So I never advise any urologist for this stone diseases. You do suffer the patient for such a type of the complication. And duration of the surgery is very important for the early recovery of the patient. PCNL is hardly taken 60 to 80 minutes for this surgery. But in laparoscopic, at least 2 hours is needed for this surgery. So it is the cheapest, best, and the normal routine surgery for all urologists. So it is the PCNL is the best for the stone diseases for the 3 centimeter size stone. And some studies here. There is the chances of the adjacent structure injury in the laparoscopic surgery is the high than the PCNL. And there is the dreadful complication in all laparoscopic surgery is the chances of conversion. There is the more chances of conversion than the PCNL. So I favor the PCNL is the best for my cases. And there is no think about the radiation. It is the very acceptable is nowadays. It is the some paper from the American Urology Associations. And I think PCNL is just our AK-47. It is the widely accepted and most efficient therapy for the stone disease. Thank you.
Thank you, Dr. Kashyap. May I call upon the stage Dr. Deepankar Sharma from Apollo Hospitals for going for the lap pyelonephrotomy for this case.
Good afternoon, everybody. I'm Dr. Deepankar. I'm from Apollo Hospitals. I would like to congratulate my colleague for a wonderful presentation. I'd like to start with my case now. What we are presented here, there's a 65-year-old gentleman. He has a stone in the left pelvis for a 5 years duration. The stone is quite big, as you can see, with around 3.5 centimeter to 3 into 3 centimeters in its dimensions. What I would like to tell you is that I would like to go a little apart and think out of the box. First of all, I would prefer to go for a lap pyelolithotomy, and this is not without evidence. I have a few points to talk about. For example, this procedure has been proven to be having decreased blood loss. There is higher stone-free rates. There are lower auxiliary procedures and retreatment rates. There is greater increase in the split function. Also, there is less post-operative fever as well as septic complications. And also, there are lower blood transfusion rates. Let me elaborate a little bit. Decreased blood loss. This is very important. As a surgeon, I would always like to have my patient to not bleed. During a lap pyelolithotomy procedures, there is a fall in blood hemoglobin levels of only 0.5 grams in average. Also, if you measure it, around only 40 to 50 mL of blood loss is seen during a lap pyelolithotomy procedures, whereas in a PCNL, having excess of 200 mL of blood loss is quite common. Also, I would like to say that in any case where there is a stone, our main goal is to have a complete clearance rate. In a single session with a lap pyelolithotomy, there are studies where we have more than 80 to 100% cases of complete stone clearance, whereas in a PCNL, there is much lesser. For example, there are studies where it has been said that there is only 60 to 80% of stone clearance rates in a single session. Because of that, if we have fragments left in the system, there will be need for higher auxiliary procedures and retreatment rates in a case of PCNL. What happens because of that? Infection, and also the stone recurrence rates will also go up. There is greater increase in the split function. Since we are not meddling with the renal parenchyma and we are preserving everything, that is why there are studies, we have seen that the split function of that side of the kidney will always be greater in a case of lap pyelolithotomy. Since we are breaking a stone which harbors bacteria, and there is insufflation of liquids, that is NS, during the PCNL, which leads to increased intrapelvic pressures, there will be contamination of the blood with bacteria, leading to increased infections in the post-operative period. There is post-operative fever in up to 20% of the cases of PCNL, whereas in laparoscopic pyelolithotomy, there is hardly 5% chances of having post-operative fever. There is also higher risks of having a septic shock in a post-PCNL case. For example, in my case, where it is a 3.5 centimeter stone, there will be stone fragments left all inside the pelvis, and as well as it will lead to infective complications. Also, in intraoperative as well as post-operative period, there will be much less requirement of blood transfusions. All these things lead me to decide for this patient that a lap pyelolithotomy will be a much better choice of procedure. This is because of the principle behind the surgery. During a pyelolithotomy, what we do is that we remove the stone integrally. That is, we do not break the stone at all. Thus, there will, and also we approach the kidney not through the parenchyma. Since kidney are very vascular organs, any damage to the kidney parenchyma will be permanent. What we do is that we remove the stone integrally, as well as we do not have to use NS. Thus, we do not have to increase the intrapelvic pressure. This is not without evidence. There are multiple meta-analyses that have shown that pyelolithotomy has higher stone-free rates, there are lower blood transfusion rates, there is lower bleeding, there is fewer hemoglobin decrease of maybe 0.5 grams, and there is less post-op fever and lower requirement of auxiliary procedures as well. Thus, we do not need retreatment as well. This is not the only study. There are other studies which have proven that this is what is the truth. Now, coming to the learning curve, it is said that lap pylolithotomy will require higher and a steeper learning curve. That is because we are usually not easy going for intracorporeal suturing, but with big training institutes and better training, we will be able to do it easily. Even for a PCNL, it is said unless you have done 50 PCNLs, you are not aware what a real PCNL is. And it goes same for the lap pylolithotomy as well. If you are going for cases, you are selecting more cases, then only we'll be able to learn that yes, lap pylolithotomy is actually something that we should actually go for. There are some other studies as well which say that the mean operative time, although it is longer for a lap pylolithotomy, but the thing is, if you are compensating on behalf of lower complication rate, lower infection rates, then it is okay. Longer operative time for a lap pylolithotomy case is maybe by a minute, but that is okay because the patient is not suffering. Thank you.
Thanks, Dr. Deepankar. May I call upon the stage Dr. Vishal for rebuttal?
My dear colleague told for the blood loss, so many studies are showing the blood loss is not significant in the PCNL for such a huge stone, and blood loss is just less than 1% in the PCNL is so many study and written in the Campbell, and the blood loss is just managed by the single 1 unit transfusion very rarely, and if any dreadful complication you think, then very minimal invasive technique is available in our hospital, so it is not a big deal for the huge stone. And split function is so many studies are showing there is no my patient has no any comorbidity, no any diabetes mellitus, no any hypertension. My patient is healthy, and so kidney function is well, and there is no any protocol for the follow up the function with the split function. And I think there is no. And my study, and I have already given the slide, in a study showing there is no major differences, no significant p-value for the differences with the lap and the PCNL for the split function. And the chances of sepsis is the same. Your stone is a maggot in the transabdominal cavity, and chances of the transmission of the infection is the high. But in my cases, sepsis is the same rate. There is no any extra beneficial for laparoscopic surgery. And you must be, and I think all urologists are a specialist in the endourologist, but I think not all urologists are a specialist in the laparoscopic surgery, and especially in the suturing technique. And those are skill you must need it extra for this stone. Thank you.
Dr. Deepankar, please stand to your point.
Some of the points that I would like to figure out is that, about the learning curve, with more and more advances coming up, we are going into robotics and all, so eventually you will have to learn intracorporeal suturing techniques. So if you are learning for an intracorporeal suturing technique, then lap pylolithotomy, then why not? Coming to the septic part. Septic shock is dangerous for an 85-year-old gentleman. If you are going for a surgery, that is going to have a 2.4% chance of him having landing into a septic shock. Then how is it fair, where you can give a much lower chance with a lap pylolithotomy procedure? Again, coming for bleeding. Bleeding is significant. Bleeding is much more significant in a PCNL case. We have seen every day, all the time. Coming to other causes, for example, you said that there is a need for 3 ports, but there are studies that shows that the post-op analgesia need is actually more in a case of PCNL. Longer operative times, you said before, that can also be mitigated by using barb sutures for a pyloplasty, as well as the bigger incision that you said is that we can minimize that using an endo extraction bag as well. So I think that I will stand my case and obviously choose a case of 3.5 centimeter renal stone and tackle with a lap pylolithotomy. Thank you.
Thanks to both. Any comment or any questions from the audience? Or we can move to the next debate. So we are moving for the next debate.
For our next debate, I would like to call upon Dr. Anand Biani from Arjikar Medical College and Dr. Ajit Gupta from Fortis Hospital. Our next debate topic is radical prostrectomy versus radiotherapy as primary modality in T3A of B N0 M0 CA prostate. In a nutshell, I will summarize the case. This is a 65 years old man having lower urinary tract symptoms for last 2 years. PSA is 25, ultrasound 45 gram prostate, post-void residue 50 ml. Upon uroflowmetry, the Qmax is 14 ml per second, prolonged flow, voided volume is 340 ml. DRE findings, hard right lobe, clinically suspected as T3 tumor. MRI showing T3A right lobe extra capsular extension, right seminal vesicle involvement might be there. No regional lymph nodes, bone scan normal. Trans-guided prostate biopsy was done, which reveals gradation 4+3 staging and perineural invasion on right side. No lymphovascular invasion. Now, I will call upon Dr. Anand Biani, who will say in favor of surgery for this T3 CA prostate case. You know the T3 tumor? Yes. Okay. You proceed accordingly. For you.
Good afternoon, everyone. Today we are going to witness a big fight on a topic which has been a debate since long. Surgery versus radiotherapy, T3A, T3B, M0 prostate cancer. My name is Dr. Anand Biani and I'm going to speak on surgery for the above case. So where do we define the T3 cancers? It is basically defined in case of locally advanced cancers, but locally advanced itself has varied definitions which was seen in the varied studies as well as the international guidelines. We'll stick to the EAU guidelines, which is having C, T3, T4, and clinical N+. So what is a T3 cancer? T3 cancer is something which has breached the capsule and has invaded into the local structures. So why is this LAPC such a big deal? Because this has a very high level of biochemical recurrence, chances of clinical progression and local progression, and has the chances of metastatic disease and death if it is left untreated. So it's an aggressive disease and we have to aggressively treat the same. So in going into the past, there was an inclination for radiotherapy as the primary treatment. But then it was seen that surgery had given suboptimal results. But there has been over a decade a change in the pattern leading to more focus onto the surgical aspect. It is the EAU guidelines which also has until 2014 not entered surgery as a standard option for the prostate cancer, but since 2015, primary radical prostatectomy along with the lymph node dissection has been recommended as a multimodality treatment. So why has there been a paradigm shift? We'll get the answers followingly. So what is the most important motto of any cancer? It is the overall survival following any therapy. As Wang et al. Presented, he found that radical prostatectomy has more chances of cancer-specific survival and overall survival with respect to the radiotherapy, thereby prolonging the survival time of the patients. It was a similar study done by Berg et al. He also found that the overall survival benefit was more in surgery with respect to radiotherapy, but his study was restricted to young people and healthy men who were less than 65 years of age. Locally advanced prostate cancers are heterogeneous in nature. Milanas et al. Did a study and he found that T3 cancers, if surgery was done, it can give very good cancer results and survival if the patient is having a PSA of less than 10 and a Gleason score of less than 7, suggesting that the PSA and Gleason score has a significant impact on survival. So as we see, the surgery has a very important role on overall survival, but it actually also has a very important role on histopathology. It helps us to accurately stage the disease and thereby help us to better stratify the patients so that we are able to optimally judge which patients will need the adjuvant radiotherapy and adjuvant treatments, as well as those who are not needing, preventing them from potential harmful treatments. This is also a study which says that the pathological stage has a significant predictor of biochemical recurrence. So everything comes with a cost. Surgery versus radiation, as we can see here, over a period of 5 years, we find that erectile function, urinary incontinence, bowel dysfunction, as well as the second cancers are more within the radiation therapy group with respect to the surgery, although the mortality rate between the both groups were found to be the same. It was a study done by Nem et al. Who showed that patients who were receiving radiotherapy had a higher incidence of complications regarding to hospital admissions, rectal anal procedures, and open surgical procedures. So basically, the most important point that we need to point out is that patients who are receiving radiotherapy have always a higher chances of second cancers, particularly relating to the smoking-related cancers like lung, bladder, and non-melanoma like skin cancers. So is there any need of an adjuvant therapy? Yes, there is some need in patients who are particularly having, after surgery, higher chances of progression and also recurrence, which can be seen by certain bad prognostic factors like the positive surgical margins, extraprostatic extensions, and seminal vesicle invasions. The adjuvant radiotherapy and adjuvant androgen deprivation therapy are certain parts of the multimodality treatment which can confer good long-term cancer control. So what is the basic agenda? The definite answer is still awaiting, whether it is radiotherapy or it is surgery. The time will only tell. The biggest randomized study which is undergoing is the SPG-SCG-15, and we are still awaiting for the answers to come, but we are very hopeful that once the study is conducted, we'll be getting the final verdict of it. So what is the future? The future is the robotic surgery. We have already entered into the path of it, as seen by Takashi et al., who did a study and found that robotic-assisted radical prostatectomy has less amount of the positive surgical margins and biochemical recurrence with respect to the open surgery. The robotic surgery has already expanded its indications in high-risk, locally advanced, metastatic, and recurrent prostate cancers, and thereby enabling us to go for a nerve-sparing radical prostatectomy even in the high-risk disease. There has been advancement within the imaging techniques like the PET PSMA scans, by which we are able to do radio-guided surgeries so that we'll be able to remove all the lymph nodes, better stratify the patients, and better help them for the further managements. Novel systems have come across to identify the capsule involvement, which will be done by the more accuracy and precision with the help of three-dimensional reconstructive technology, as can be seen here, helping in nerve-sparing radical, robotic-assisted radical prostatectomy. So to conclude, the surgery helps in accurate staging, removes the benign sources of PSA, guiding future therapy and possibly avoiding the ADT. It possibly avoids the urinary and bowel toxicities, risk of secondary malignancies, and it's an effective primary modality, reducing overtreatment and improves the outcomes. Psychologically also, it is very appealing and has less amount of hospital admissions. Minimally invasive and robotic surgeries have revolutionized the treatment modality. Thank you.
Thank you, Dr. Vianney, for being in time. I will now call upon Dr. Ajit Gupta from Fortis Hospital to say in favor of radiation therapy. For the audience, sorry to talk in between, the lunch is on. You can take it till 2:30 by any time.
Good afternoon all. My name is Ajit Gupta and I'm from Fortis Hospital. Today I'm going to talk on the behalf of radiotherapy for the treatment of clinical stage T3 N0M0. As my colleague Dr. Biari has already explained the staging of this T3 categorized into 3A and 3B, I'm not going into detail. Now, coming to the treatment goals for any cancer patients. What are the goals? The first one is obviously the cure of the disease, prolonged survival, and improved quality of life. And obviously the survival without any metastasis. So the question today is, can we rely on radiotherapy to achieve the goals which I have mentioned? And where does this radiotherapy stands in comparison to radical prostatectomy for this clinical stage T3 for carcinoma prostate? This is the journal published in 2017, which says that treatment of locally advanced prostate carcinoma, that is stage 3, this was published in Japanese Journal of Clinical Urology. Here the patients were divided into 3 groups. The first one was for radical prostatectomy, the second was radiotherapy, and the third was one were treated with hormone therapy. Here, the cancer-specific mortality for the operation group and the radiation group was almost similar, but for the operation group, the selection bias was there as the healthy patient and the patients with less comorbidity were selected for the operation group, while the patients with a higher age group and with more comorbidity were put under the treatment of radiation therapy. This graph also shows that at 10 years of follow-up, the operation group and the radiotherapy group were similar in the respect of cancer-specific survival. And this is the next study which was done in the year 2021 and was published in European Urology Open Science. This says that comparative survival outcomes of high-risk prostate cancer which were treated with radical prostatectomy or definitive radiotherapy regimens. Here also we can see that the 5-year cancer-specific mortality and 10-year cancer-specific mortality in the group of radical prostatectomy, it was 1.5 and 5.7 respectively. And the group which were treated with radiotherapy, it was lesser than the group of the patient which were treated with radical prostatectomy, which was 1 and 3.3 in 5-year cancer-specific mortality and 10-year cancer-specific mortality rate so far concerned. So, coming to comparison of monotherapy between the radical prostate and radiotherapy, what does the EAU guidelines recommend for radical prostatectomy for T3 cancer prostate? The size of the tumor should be small. The PSA value should be less than 20. The Gleason score should be 8, and obviously the life expectancy should be more than 10 years. This is the guideline, as Dr. Biani already told, that the EAU guidelines, which is 2020, here the radical prostatectomy for locally advanced prostate carcinoma is for highly selected patients, and it cannot be used as a monotherapy. It is used as a multimodal therapy. But in the same guideline, on the lower end, we can see that the radiotherapy can be used, and the strength rating is strong for that. This is a publication published in 2021, and this says that it characterizes the surgical radiotherapy outcomes in non-metastatic high-risk prostate cancer, and the results are same, which favors the radiotherapy when it was compared with the radical prostate surgery in respect to the cancer-specific mortality. So what needs surgery for the T3 carcinoma prostate? As in T3 there is extra capsular extension or the involvement of the seminal vesicle, there is extensive need of resection to achieve the R0 status, and due to the limited ability to excise the wide margin of healthy tissue, that's why we are unable to achieve that R0 status. And studies have shown that in case of T3 cancer of prostate, those who underwent radical prostatectomy, the 5 years and 10 years clinical progression were 41% and 69% respectively. And also the surgical margin positivity in these cases were up to 47%. So radical prostatectomy is considered as second treatment for T3 cancer prostate as noted in NCCN, AUA and EAU guidelines. Now coming to the quality of life. This shows that in this also, the radiotherapy group had better sexual function and urinary incontinence. Thank you, sir.
Thank you, Ajit.
No, okay, thank you.
Now, I will like to call upon Anand Biani. Do you have any rebuttal?
Thank you, Ajit Gupta. It was a wonderful presentation. I'll just point out certain things that you have told in your slide. First of all, it's regarding the survival. There has been various and many studies which have proven that it is the radical prostatectomy which has overall as well as cancer-specific survival on a long term, which is much higher with respect to the radiotherapy. You also told about the radical prostatectomy as monotherapy. It's true that it has been in guidelines as multimodal therapy, but it has also been seen in histopathology after the surgery that there is 30% chances that there is a downgrading of the downgrading that has been seen. And 30% cases of patients may be treated as monotherapy itself. You also said about the fact that the extensive resection is required and R1 cannot be achieved. But the fact is, with the advancement of minimally invasive techniques and robotics, and thereafter because of the huge amount, the magnification as well as the 3D reconstruction that we get, we are able to achieve nowadays a good amount of margins even without disturbing the oncological outcomes. The side effects, as we talked about the quality of life, I would like to say that as I had showed in my slides, initial side effects obviously is more within the surgical part, but on the long run, with a 5-year follow-up, what we find is more amount of complications are there with the radiotherapy, but not with the surgery. So because of these advancements that's taking place in the minimally invasive techniques, robotics, which is coming as a future techniques, we are able to have a better functional oncological outcomes with a less amount of morbidity that can be seen. Thank you so much.
Thank you, Anand. Ajit, do you have any rebuttal? Yes. Please proceed.
Okay, as you said that with the advent of this radical prostatic robot surgery using for this radical prostatectomy, as the cancer has already spread extra to the capsule and it has invaded the in 3B group, it has invaded the seminal vesicle. It is very difficult to achieve that R0 margin. And with the advent of, as you talked about the complication rate about the radiotherapy, with advent of the intensity modulated radiotherapy, we can concentrate the radiation to the tumor, and it can confine within the capsule, and so the toxicity which were earlier due to that radiation therapy, which we cannot get nowadays.
Thank you. Now, Anand and Ajit, both please be on dais. I now like to invite comment from our audience and respected sirs. Please, do you have any questions or any expert comment on this topic? This is the most debatable topic for the last few years, also after the more and more availability of robot with us. Sir, Tarunda, do you have any comment? Or to summarize?
I think this debate is likely to continue for another few years. Yes. But a very important factor which I would like to highlight in radiotherapy studies, you will always find a cancer-specific mortality data. You will hardly ever find an OS data. In a surgical series, you will tend to find an OS data. I believe it is important to have an OS data also because the cancer-specific survival data will actually cut off all the patients from the analysis who had a complication because of radiotherapy, like a radiation cystitis, bleeding because of radiation cystitis, proctitis. So if we are comparing both the modalities, I believe it is important to compare and OS specifically in this particular scenario?
As a surgeon, we always prefer to go for surgery whenever the scenario is within our resectable criteria. But as we are also doing private practice, we have to also keep up in mind that the side effects of the surgery and radiotherapy. So, if we don't have any other questions from the audience, we proceed for our next debate. Thank you, Biyani and Ajit. Our next debate is a three-way battle between Dr. Piyush Kumar Patwani from Arjikar Medical College, Dr. Ehsan Khare from IPGMR, and Dr. Saeed Hamid Kumar from RKM. Our debate topic is for large prostate. It's a 200 plus gram prostate, and here we will debate upon between open prostatectomy versus Hollap versus transurethral bipolar enucleation of prostate. I will give a short case scenario to make the thing interesting. This is a 60-year male patient who have a recurrent acute retention of urine and failed catheter-free trial. Clinically smooth, firm, non-tender prostate of grade 4. Uroflowmetry has low flow pattern when he was evaluated previously. Ultrasound shows 253 gram prostate with prominent median lobe, and post-void residual was more than 600 ml when he was evaluated before retention. So, without wasting further time, I would like to call upon Piyush Kumar Patwani from Arjikar Medical College, who will speak. Oh, sorry, from National Medical College, sorry sir, who will speak in favor of open prostatectomy.
Respected teacher, my seniors, colleague and junior, today's debate is on recurrent urinary tract infection with lower urinary tract symptom in a 60-year gentleman with a 220 gram prostate. For the sake of this debate, our patient is planned for a surgical management. Treatment options are either simple prostatectomy or various enucleation techniques. Presently, the gold standard for such a patient is a open surgical prostatectomy. It can either be done by a suprapubic method or a retropubic way. Now, these are the indication of a simple prostatectomy, which include large gland more than 75 gram, associated large bladder stone, bladder diverticulum requiring surgery, intrinsically narrow urethra, ankylosis of the hip, associated inguinal hernia. These are the advantages of an open simple prostatectomy, which include complete enucleation of the prostate, least recurrence or the retreatment rate among the various treatment options, least urethral morbidity, short learning curve, short operative time, and least expensive. Now, this is a study which shows that after during a long-term follow-up after open prostatectomy, IPSS score improves by around 60 to 80%, quality of life score improves by same 60 to 80%, Qmax has increases by around 350% from the pre-operative level, and PVR decreases by around 90 to 95%. This is another nationwide study from the Austria, which include all the databases from the country over a decade, which says that long-term pretreatment rate are the gold standard parameter regarding the efficacy of any treatment for the benign prostatic enlargement. The study shows that around 20,000 patients underwent TURP, while 1,200 patients underwent open prostatectomy. At 8 years follow-up, around 12.7% patient had a secondary endoscopic intervention, but it was just 8.8% for the open prostate group. And total of 8.3% patient needed secondary TURP or open prostatectomy, while it was only 4.3% in the open prostate group. Now, coming on to a disadvantage of the transurethral enucleation, it has a steep learning curve, urethral morbidity is more, it requires specialized instruments which are costly, device malfunction is known, it has ergonomic problem, sometimes staging procedures are needed, and there is more recurrence. This is a randomized control trial, one of the few for the Hollap versus open prostate, which shows that a learning curve of more than 200 cases are required to attempt a Hollap for the patient more than 70 grams prostate. This is another study which shows that for monopolar TURP, stricture rate is around 9.3%. For the bipolar, it increases to around 19%, while the open prostate has only 4.8% urethral stricture rate. This is another study which shows that around 27% patient belong to the Holmium group in the study done by Kulkarni sir. This is the cost analysis, this is a list of various equipment required to set up a Hollap facility in a center. Now this is a cartoon depicting from our childhood days about Uncle Scrooge from the DuckTales, where he has lots of money, gold coins, and he used to swim in that. We need that kind of money to set up a Hollap in a center. Now coming on to bipolar, it requires little less money, but it is cost intensive therapy. Now the cost analysis shows that Hollap requires around $3,000 more as compared to the conventional TURP, which is around 2.5 lakh in Indian currency. Now device malfunction is known. In Hollap, morcellation dysfunction is the most common device malfunction. Now coming on to ergonomics, the most commonly muscle strains are from the neck, followed by back, shoulder, and hand. Another nationwide study in Japan which showed that blood transfusion rate in all the databases showed that Hollap required 7.8% patient required blood transfusion, while for bipolar it was around 25%. This is same study which shows that in the database that average resection was of 35 gram, and still it took 2 hours, around 127 minutes to complete the procedure with a 7.8% of blood transfusion rate and a 6% urethral stricture rate. And this study proves that around 30 to 40% patients still undergo open procedure in developed countries. Now coming on to the latest guideline 2021, which showed that the open approach has all level 1 evidence. Still, Europeans consider Hollap as an alternate to open prostate, where all the summary of evidence shows that Hollap is compared to the TURP. Everywhere it is TURP is written, never it is compared to open prostate. Same belongs to the transurethral enucleation, where it is only compared to prostate, and it is a newer technique with a weak evidence. But when we go for AUA, they consider only 3 options for a large prostate as a simple prostatectomy, Hollap, or Thulap. And they recommend that depending on the expertise of the surgeon, we can opt for either of these 3. In our country, we follow the European way. Now, this is the irony of the simple prostate, where despite strong evidence, level 1, by EAU 2021, it is considered obsolete these days, as it is less appealing to urologists and the patients, and is less lucrative in terms of money. So it is now considered a dying art. Now this is the image which shows that giving the best result open prostatectomy, looking upon a field of players of various endourological procedures which are trying to achieve what open prostate has achieved over all these years regarding the treatment results. Thank you.
Thank you, Piyush, for keeping on time exactly before 6 minutes. Now we have a chair in the front row, and see your 2 opponents to debate. Now I'd like to call upon Eshan Khade from IPGMR, who will speak in favor of Hollap.
Good afternoon, respected teachers. Myself, Dr. Shans. I'll be speaking in the favor of Hollap for this 60-year-old gentleman with a known huge prostatomegaly with history of recurrent UTI with lower unit tract symptoms. Now, when this patient comes to a urologist, what he thinks of? He wants to be symptom-free with no or minimum complications. He wants to be catheter-free and wants a minimum hospital stay. What a urologist will think about this patient? He wants to make the patient symptom-free with minimum complications, with minimum needs for ancillary procedures, and he also wants the patient to have a shorter stay in the hospital. By looking all this, I think Hollap is the only technique among the other 2 options, the best for this patient. Why? First of all, why Hollap is better than open prostatectomy? Because it causes decreased blood loss, it makes the patient early catheter-free, decreased hospital stay, decreased complications, immediate and durable positive outcomes, and decreased ancillary procedures. Now, I'll explain why. This is the meta-analysis showing how Hollap is better than open prostatectomy in terms of the length of the stay, catheter time, and the transfusion rate, and the decrease in the hemoglobin level. It is showing that Hollap is much better than the open prostatectomy. Second, this is the review article which shows Hollap, there was significant less blood loss in the patients, and there was a shorter hospital stay with lesser catheter duration. This is also a review article comparing, which showed that Hollap is a size-independent procedure and has no significant influence on the hemoglobin level. This is a 2-year follow-up study that my friend has shown, but he has not shown that there was overall correlation between the hemoglobin loss in all prostate size was very weak. Now this is again a review article which shows the Hollap shows a long-term durability in terms of subjective and objective outcomes for more than 10 years. And EAU and AUA recommend as an size-independent procedure in terms of as an alternative to open prostrectomy. For now, in this era, it is the gold standard. Now, this is an experience with the 1,000 Hollap lasers, which show the complication rates of Hollap are much lower, with less needs for the secondary procedures, with long-term durable results. Now, this is a study which shows in Hollap, the perioperative morbidity and the postoperative fixation do not depend on prostate size. So in this patient with the prostrectomy 220 gram, it can easily be done. As per my colleague was talking about the cost, according to this study, the overall hospitalization cost of the Hollap was 10% less than the open prostrectomy. Now, how Hollap is better than the bipolar TUP, my next colleague will be saying. Hollap is the following good point: there is decreased blood loss, it makes the patient early catheter free, decreased operative time, decreased blood irrigation, immediate positive outcome, decreased ancillary procedures, and increased enucleate weight. This is a review article showing Hollap had lower operative time, shorter catheterization time, lower blood irrigation time, and higher enucleate weight when compared to bipolar TUP. This is a meta-analysis showing that there was a huge difference, significant difference when Hollap was compared to bipolar TUP in terms of small reduction in hemoglobin, shorter catheterization duration, and shorter hospital stay, all favoring the lasers. This is a meta-analysis showing the operative time was much lesser in the Hollap group when compared to the bipolar TUP group. It was approximately 15-20 less in the Hollap group. This is a meta-analysis showing the Hollap is preferred for bipolar TUP because of higher improvement in the maximum flow rate as well as the lower post-word residue in the long term and with fewer irritative symptoms post-operatively. This is randomized control time which showed the operating time was much lesser it was in the Hollap group when compared to bipolar TUP group. As per the EAU guidelines, it strongly recommends Hollap YAG laser to the man with moderate to severe LUTS with large prostate, while there is a weak recommendation for the bipolar TUP in such cases. So, in this patient, why Hollap should be used? Because it is independent of prostate size, it takes less operative time, more tissue extraction, decreased need for post-op irrigation, shorter catheter duration, minimum blood loss, minimum complications, and decreased hospital stay, and less costly. In the end, I will say the Hollap is the best, and other two are there's nothing to debate about it. Thank you.
Thank you, Dr. Ishan, for strictly following the time guidelines. You will please have a seat. And we have our third debater in this topic, Dr. Syed Hamid Kumar from RKM, who will speak in favor of bipolar enucleation.
Good afternoon, teachers and colleagues. I am Dr. Shahid, and I will be speaking for bipolar enucleation of the prostate. Is it really the best method for this large prostate, 220 gram prostate? I would say yes. Firstly, a brief introduction about bipolar system, how it works. The most commonly used bipolar technology is plasma kinetic tissue management system. It utilizes a specialized loop that incorporates both the active and the return portions in same electrode. This is a bipolar loop which uses a platinum iridium instead of the tungsten. Why so? Because tungsten cannot withstand the stress of the plasma. So how does bipolar work? Basically, all of us know that plasma is one of the 4 fundamental states of the matter, where energy is applied to a gas, converting it into plasma. Due to its conductivity, plasma enables energy to cross at lower levels. This allows for lower operating temperatures and therefore less thermal spread. In 2006, Gilling Group described the bipolar enucleation technique. It can be done with a handle, button, or Herman handle, utilizing a current of 160 watt for cutting and 80 watt for coagulation. So what are the effects of the bipolar? It allows tissue resection at lower temperatures and lower voltage, more simultaneous cutting of the tissue with sealing of vessels, thus leading to overall improved hemostasis. These lower voltage and temperature used in plasma system minimizes the tissue charring, decreases unnecessary tissue coagulation, and decrease in storage symptoms. A preliminary note about transurethral detachment and resection of BPH was done by Hiroka in 1983. So what next? There are many methods of enucleation as already said. Evolution of technology has resulted in different modalities like Hollap, Tholiap, and bipolar enucleation. A little comparison between these different energy sources. Holmium was introduced in 1993, is a pulsed emission with a penetration of 0.3 to 0.4 mm, 2140 nanometer wavelength. Thulium was introduced in 2005. It is a continuous emission with a penetration of 0.25 mm and 2013 nanometer wavelength. Bipolar was introduced in 1998, works by plasma formation and has a penetration of 0.45 mm. These enucleation techniques, these can be done by 3-lobe, 2-lobe, en-bloc, and hybrid, but techniques are different, but success ultimately depends upon patient parameters, prostate size and shape, and the patient outcomes. So what do the guidelines say? European guidelines say that open prostate is an effective and durable procedure, but at the same time, it is the most invasive surgical method. So the recommendations are open prostatectomy should be offered in absence of other endoscopic enucleation methods. A word about bipolar guidelines. They say that bipolar enucleation of prostate offers favorable mid to long-term efficacy compared to TURP with favorable perioperative modalities. In 2016, Thomas Herman presented a paper which was titled Enucleation is Enucleation is Enucleation is Enucleation. In this paper, they demonstrated that there were no significant differences between endoscopic enucleation and open prostatectomy. However, perioperative parameters were better in endoscopic enucleation and blood transfusion was less. In this randomized control trial, 240 patients, 46% went open prostatectomy and 54% had bipolar enucleation. There were durable results in bipolar at 3 years. Reintervention rates were 7.5% in open group and 5% in bipolar, and less high-grade complications in bipolar TURP. A 12-month follow-up for open prostate for more than 80 cc and bipolar enucleation, there was decrease in the hemoglobin level, catheter time, hospital stay. All these parameters were less in bipolar enucleation, and early and late complications all were significantly less in bipolar enucleation when compared to open prostate. This study compared perioperative features like postoperative hematuria, hemoglobin drop, blood transfusion, catheterization period, and hospital stay. All were less in bipolar enucleation when compared to open prostate. Similarly, postoperative complications like recatheterization rates were only 1.4% as against 8.6% in open prostate. So where does bipolar stand against the lasers? This was a study where perioperative recovery, efficacy, and complications were studied. Efficacy outcomes and safety profiles, they were comparable in laser and bipolar. Another systematic review, it was seen that on an average, Hollap had longer operative time by 16.72 minutes than bipolar. There was no relevant difference in mean resected tissue, and bipolar was cost effective. Another trial comparing bipolar enucleation with holmium, it was seen that both modalities are comparable for large prostates. So another retrospective analysis of data, 62 patients of Hollap and 76 patients of bipolar enucleation. Comparison of sexual and ejaculatory function after Hollap was done. Both procedures were valid alternatives, comparable urinary and sexual outcomes. However, in first months after surgery, Hollap patients presented with more ejaculatory difficulties and physical pain. So the final message is endoscopic enucleation is equivalent to open prostatectomy in functional results. However, it is far superior in perioperative results. Hollap and bipolar are comparable in safety and efficacy, but bipolar is cost effective, reproducible, comparable urinary and sexual outcomes in long term, easier and wider availability. Thank you.
Thanks, Dr. Shahid, for your presentation. Please be on the stage. May I call upon Dr. Piyush and Dr. Ehsan for their rebuttal. First, Dr. Piyush.
Do you have slide?
Yes.
You have given?
Yeah, it is.
Dr. Shahid, you are having slides? Or you, so then you speak? No. Hey, he's having some time.
It's ready, it's ready.
Now, coming to the rebuttal, we need to understand that RCTs are the only things which are reported. Because as a resident surgeon, during my surgery days, my sir used to tell me, we know what is being reported, but we don't know what is not reported. So we need to understand that RCTs are done in a controlled environment. What about the ground reality which we want to see? What is actually happening in the ground? Now this study was done in Japan. It's a nationwide study of the database which shows that it was more than 600 patients underwent Hollap in Japan in the whole year, which showed that average operative time was more than 2 hours. For a gland resection, average weight was 35 grams. So it leads to more urethral morbidity. Also, whatever my friend has discussed that complications are less, but it is proven that around 7.8% is the average rate of blood transfusion. And complications, in the same study, it shows that 15% of the patient develop complication following Hollap, which is a very large number, including 6% patient developing urethral stricture disease. So in my point, if patient developing urethral stricture disease is good, or having a lower abdominal scar of around 5 to 6 centimeter is better. Now coming to the study which my friend has shown, this is a randomized control trial which clearly proves that the operative time is much less for the open prostate group, while a specimen weight taken out from the controlled environment, it is still open prostate has a bigger specimen taken out. My friend told us that the hemoglobin level is significantly decreased in Hollap level, but we need to consider the fact that hemoglobin drops by around 2 gram per deciliter in Hollap, and it is 1 gram extra in a open prostate group. Now, he failed to mention about the decrease in the sexual function post-Hollap, which is one of the major complications. Also, my friend told about the plasma enucleation, and it is shown by the studies that surgery time in the open prostate is less than the plasma enucleation by bipolar technique, and post-operative hemoglobin levels are equivalent in various studies. So I don't need any useful studies. I need studies which are indisputable to replace open prostate as a gold standard. Thank you.
Okay, next, Dr. Asian Khare for your rebuttal.
I just want to say to my friend, he just questioned the type of the studies. He's just saying RCT are done as only, we should not look for the type of the study. We should only observe what we are doing in OT. So what is the basis of that? Second thing, he said that the blood loss is much less in the Hollap. You can't doubt about it. Open prostate has blood loss, and we keep the blood in hand before taking the patient to a surgery. And in such a patient with a clinical scenario of 220 gram prostate, we have to keep a blood in hand. Third thing, he is telling about the cost. Overall cost, I think we are thinking about the cost in one patient, but we are not looking at the longer perspective when we will be having a setup in a hospital and many patients will be operated. Then the overall cost will be much less. And I have already shown you in the paper that the overall cost of the Hollap was 10% lower than the open prostatectomy. Then my patient said something about the stricture. He is telling the stricture rate is much more in the Hollap group. But I will show in the same paper, the overall stricture rate was less than 3% in the Hollap group, and it was much more in the bipolar TO group, more than 3.6%, and the open prostatectomy it was 5 to 6%. Then my patient told about complications group. Complications, as my patient told, were more in Hollap. No, it's not so. He's telling about 30% complications, rather than it is less than 5% or less than 3%, I should say, when compared to both the technique. Now, for the second one, my patient for a bipolar TUP, he said there is a more enucleated weight. No, the more enucleated weight that we do from the Hollap per minute is more for the Hollap rather than the bipolar TUP. Though sexual functions are initially not good with Hollap, but in long term it gets improved. And in one study, it has shown that 75% of the international ejection fraction IEF score has improved paradoxically in the 75% of the cases for Hollap. Thank you.
Next, Dr. Shahid for your rebuttal.
So my friends were talking about complication rates, cost effectiveness. Just one or two studies. This was a 6-year results of randomized control trial which compared plasma kinetic enucleation with open prostatectomy. Decrease in hemoglobin was significantly less in bipolar enucleation when compared to open prostatectomy. Duration of catheterization was less and post-operative hospital stay was less. Regarding post-operative complications, as we can see, there are very minimal complications in the enucleation group when we compare it to open prostate. This is a meta-analysis which included 109 trials, 13,676 patients, and compared 9 surgical modalities. So the overall functional outcomes, Qmax at 12 months after surgical treatment, the best modality was bipolar enucleation, and IPSS at 12 months, the best 3 methods were diode, followed by bipolar enucleation, and then holmium laser. This is a forest diagram where we can see IPSS at 6 months, 24 months, and 36 months. Bipolar is ahead of all other modalities. And for Qmax, at 6 months, 12 months, 24 months, 36 months, it is ahead of all other modalities. So regarding cost effectiveness, this study shows that bipolar is the most cost-effective enucleation method because bipolar is already offered in the clinic. Bipolar is the only enucleation method that can be performed using same standard equipment as for bipolar TURP. So the capital costs of Hollap are far higher than bipolar. Bipolar enucleation, it is size independent, yes. Intraoperatively safe and efficacious, yes. Better perioperative matters, yes. Less steep learning curve, of course, yes. And cost effective, of course, yes. So do we need more? I don't think so. Thank you.
Thanks to all three of you. Any questions from the audience? Yes, please.
The learning curve is much more and the duration of surgery is much more compared to the other two techniques. So in the bargain, the stricture formation, whatever little with my experience I've seen, it's much more, irrespective of this 3% or whatever you have quoted. And again, as an andrologist, I feel the sexual function thing is very important. And again, it goes against Hollap. So, thank you.
So, Dr. Dilip Pal sir, have you any, Dr. Kollan sir, do you have any questions?
Comment. No, I congratulate all the speakers for an excellent presentations. Here, the debate is on two levels. One is open versus endoscopic, and that's a long-standing debate. And there's no issue that endoscopic maneuvers will allow for easier patient recovery, and so that is one level of the debate. The other level of the debate is enucleation versus open enucleation versus endoscopy. There, the most important thing is control of hemorrhage. And I think none of the speakers actually made the points as to why open is better for hemostasis or holmium is better or bipolar is better. Here, I think you all know, but you did not stress on the point that the holmium penetration depth is more than bipolar. So it possibly, arguably causes better hemostasis, but more tissue damage, so more side effects. So that is a debate point I thought that I should, if you want to really debate. The other important thing which I think was not mentioned specifically, but it's extremely important that with the bipolar system, you can do what is known as endoscopic, you can resect the tissue with the resectoscope, with the mushroom technique, and may not detach the lobes and have to use a mosulator. So on balance, I think the debate is always there. Open prostatectomy is proven and safe, and Hollap has a longer track record, more industry backing, so more popular maybe. But I think bipolar enucleation is also feasible and arguably maybe better. I do not know if you can do it.
Thanks to you, sir. For
Sir, Malai Beda, sir.
So we are searching for enucleation by various methods. But till now, probably we are not satisfied. For that reason, we are hunting from here to here. I think when the robot will be available very easily and when it will be cheaper, I think again, like gallbladder operation, the robotic simple enucleation will come. Yes. I think. Dr. Sobnis has shown also in various places. You can comment on that.
The robotic prostrectomy, simple prostrectomy is done. It is shown to be much better. But as we know that robot has a completely different environment, the cost and various other issues are there. But I feel in all three of you, you have done quite well. And I don't know, we have done so many millions in our residency and our initial days. So we always feel confident about the open prostrectomy. But I agree with both of you that these enucleation methods will continue to have debates, and at the end, everybody will have their own personal choices. And once you master one thing, you become much better in that particular technique as compared to the others.
Professor Dilip Pal sir, you have a vast experience of open prostrectomy. Sir, please, your comment.
Open prostrectomy is very easy to do, time consuming, and blood loss, I think, not so much. It's very minimum blood loss if you can go with the proper plane. And time, whatever may be the size, maximum time taken is 45 minutes to 1 hour, not more than that at all. Regarding Hollap, I don't have any experience. Bipolar is good, but very large bipolar prostate, it takes too much time, and I think open prostrectomy is much better, much easier than a bipolar prostrectomy.
Thank you very much, sir. Any other comment from audience? As this is our last debate topic, we can have few more minutes. Professor Dilip Kormakar, sir.
My experience in neurology since 1976 onwards, when I was just passed, I worked with Professor Dhruvo Sen, and I had seen the open prostrectomy surgery with other teachers also. And when we were students, late Professor Mriganko Das used to say, prostatectomy operation is a two-stage operation. First you do a suprapubic cystostomy followed by prostatectomy. This was a training period. During our the house sepsis period, prostatectomy is a hazardous operation. There is a bleeding, and all the tables are packed up with the citrate solution or active flavin solution. I have seen this period. Then came this, I saw TURP started at I saw since BHU. Yes, initial learning period, when at that time there was no camera system. The teachers used to dissect a few chips of tissue and says, okay, right. At the time there was a severe clot retention, complication was there. After the invention of this camera, the complications, these incidents came down. The blood transfusion rate came down, stricture incidence came down, post-operative retention came down. Followed by this came bipolar resection. And this holmium, thulium. But main thing, the surgeon behind the machine, this is the important things. The expertise is the main important thing. Machine is not the important things. Anybody can do prostate. Suppose our Dr. Pradhan operate 200 grams of prostate easily by monopolar TURP. Dr. Varsner did this laser prostatectomy easily. Those who have no experience with the laser or initial exposure, it depends. So it depends on the surgeons, their expertise, etc. It's not the technique.
Dr. Kumar has to tell something.
Hello. I want to say something regarding the prostatectomy, particularly the young urologist or the budding urologist. With my experience, as Dilip has told right now, that one young urologist whatever may be the technology, whatever may be the modern instruments and all these, the finer instrument, but one must know the procedure of enucleation open prostrectomy as also the retrovic prostrectomy, that is a Millen's technique. You must know first very well, that whenever you are in danger, you can just get it out of the situation. This is my suggestion.
Thank you, sir, for your suggestion. Sabni sir, do you want to enlighten us about which one do you prefer more from Hollap and bipolar? In your institute, you are moving towards bipolar, I think.
See, we have a very peculiar situation that we still do not have the high power laser and we don't do Hollap prostrectomy in our institute. There are various reasons. Because in most of the cases, the prostate gland in our area and the patients which we get are amenable for TURP. So that remains a most important aspect, and therefore we have not started Hollap as such. The other thing is that we have so many students who are coming every year, 4 students per year, and we have to teach them the TURP. We can't just teach them Hollap, and therefore we have not acquired Hollap. As such, if you see, the surgical treatment for prostate is gradually going down because of the fantastic medical management. So what indications we had about prostrectomy 20 years back, they are much, much less today. And therefore, when the patients are coming for surgical modality, you really have to choose whether it is TURP, whether it is enucleation. In a small prostate, I personally feel enucleation is not required, although there are various different opinions. But generally about 50, 60, 70 grams prostate, you can do TURP without any problem. Results are fantastic, time and tested and proven very well beyond doubt. The questions come, as you have pointed out, that the large prostate. Then the all modalities will come, whether it is a Hollap enucleation, whether it is bipolar enucleation, or whether it is open surgery and enucleation. In my own hand, in our own hospital, we get about, in a year, about 4 to 5 such patients where the prostate is too big, so much so that the not amenable to TURP, the whole cystoscope goes inside and you hardly reach the prostate, the bladder. That was the kind of the prostate which we get. And those cases, we still prefer to do open Millen's prostrectomy. Reasons is that the younger urologists, if you see, as he pointed out, that they have not seen Millen's prostrectomy, they have not seen any open surgery for prostate. So how it is possible that they will become confident? If people have not seen any surgery, it is not possible and expect young urologists to become confident. Our era was completely different. And therefore, when we do those surgeries, maybe 2 or 3 or 4 in a year, all residents, they come and watch. And that is where we actually teach also that this is how the steps are and this is how they should be aware that such treatment option is there. But from the debate point of view, I think those who are used to Hollap will do Hollap excellently even in the small prostate or in a big prostate. Those who are used to bipolar enucleation, they will do it in an extremely nice way. So as pointed out by almost everybody, that what you are used to and what you are confident and what you have practiced is very important. So man behind machine, what Dr. Karmarkar said is very true, that if you are mastered one technique, then whether it is Hollap, whether it is bipolar, whether it is open, whether it is robotic, ultimately the results are going to be the same.
Thank you, sir. So we are coming to the end of this debate session. We are moving to the inauguration session. So Shoptorshi, can you come up on the stage and start the inauguration session?
Thanks to all debaters for your nice presentation. At the evening, at the valedictory function, we will announce the result.